So, first thing which we do in dual chamber implantation is a good venous puncture. And now you can see here the vein is oval shaped and it's bigger than artery. If the patient is properly hydrated, then we puncture it. And then this normal 7 French sheath goes in. Before that, it is dilated. And now you can see here 4 IV lines hanging there, 2 with pressurized IV bottles and 2 non-pressurized. And with this 7 French access, which is properly dilated, the tract is properly dilated, we take a normal GR diagnostic catheter with a normal Teflon wire. And with the wire, we park our catheter in the right subclavian or IJV. And then we take out the normal Teflon wire and take the super stiff wire. So the large sheath goes on super stiff wire so that it should not create trauma. Now the super stiff wire goes in, it stays there, catheter comes up, diagnostic catheter comes up, and the larger sheath is getting flushed and prepared. But before we introduce the larger sheath, we dilate the the venous access with 14, 16, 18 French dilators. It's always good to dilate, and it is mandatory in arterial. Venous also we should do it. And once the coating is activated, the sheath, large sheath, these are 26, 27 French sheaths. We take this sheath inside the fluorovision so that we are clear that it is not deviating and not causing trauma. It is just sliding over the wire. You have to push it little clockwise, just torque movement and go up. And once in RA, mid RA, you take out the dilator, keep the sheath there. And once the dilator is getting out, you need to have a negative suction so that the air doesn't get sucked in. So in all large sheath, this precaution has to be made, and then it is connected to the flush port. We also give heparin at this time. And that was the access. A is access. Now the catheter, delivery catheter is prepared. So you can see here there is a B bypass tool, C is catheter port, D is device port. We flush now the B, C and D, and then we connect the LLP, leadless spacing system, capsule and device, to this delivery catheter. So you see the catheter, we can lock it, unlock it, and we have to take the device. This is LLP. This is in a protective cover, and once we take our tethers, connect to the LLP, it has to be misaligned first. So you see, this is how it is misaligned. The proximal knob has to be rotated clockwise, and then the tethers getting misaligned, it will go inside, and once it goes inside, you have to again align it so that it stays in and holds the LLP. Now the protective sheet, what we called the it is removed, and now the device is docked. So the connection is made and it is docking is already done. We have to pull the proximal handle part, the blue part, and it is in docked, and then we take the device, the LLP. You can see how you pull it and it will be docking, and then once it is inside the sheath, covering sheath, we have locked. Now before introducing the entire delivery catheter with the device, we connect the ports with the flushes. So the first and two, access and bypass, these are large boards, so then large lumen ports, so we can connect without heparinized solution, without the pressurized bag, and the C and D, they are connected with a pressurized IV line bottle or bag, so that you can give little more force to push the enormous line. These are all heparinized solution, and de-air it and connect, and the rate should be 1 to 2 drops per second. 1 drop per second is a good one, is the ideal one. So with this 5000 heparin going in, and with this already given after the sheath access, large sheath access, the every flush port is connected. Then we take the delivery catheter and device inside. Okay, now you see this is a bypass tool. Inside that protective sleeve with the device, and now the bypass tool is inserted, and once it is inserted, it is fixed by rotating clockwise. Okay, and then the blue part, till the blue part transitions into gray, and the gray is getting disappeared, you don't see the fluoro, because the length is that much which will be inside the sheath. So till mid RA it is going inside the sheath, and then you take the sheath down rather than taking the device up. Now the sheath is down. Now after the sheath is down, we also uncover the LLP from the protective sleeve to see the blood pool impedance and to communicate the device with the programmer. Now you can see here, we see this blood pool impedance, which is around 370-380, and then once it gets in contact, the impedance should get higher. So with the septum touching it, this impedance will be high and current of injury will be there. We resheath it with the protective sleeve. We are resheathing that, and once we resheath, we lock it. The catheter is locked, and then we go in RAO with deflection on, with deflection and counterclockwise movement to make it more anterior. We go inside RV, from RA to RV entry, and once we are in RV, we now again go to some clockwise movement to make it posterior and towards septum. So RV, you see now this is towards septum, and we will confirm it in LO projection that it is towards spine. We will further confirm it by giving contrast injections. So now we are having good position, RAO 30, LAO 30, and the contrast injection is given through the sheath. You see now, through sheath we will give the contrast injection. You can take 10 ml or 20 ml, whatever, but 10 ml is my preferred way. Now you see it is not at anterior border, there is a space there, and then it is in the septum, mid septum almost. So we are okay with the position. Now we remove the brake and unsheath the device. So the protective sleeve now comes out. You see we have unlocked the catheter, and we are taking it out. This covering sleeve coming out, device remaining there. There is a good kind of movement also of the device, and you can see here it is stabilized, stable. A good current of injury, very good current of injury. We check the impedance, which is higher than the blood pool, and we see the threshold. And now the pacing threshold we are checking, and its pacing. You can see the monitor also pacing. Now once we are okay, now we are screwing the device, clockwise rotation of the blue handle, and keeping the chevron cine in other panel of the fluoro, so that we can be sure that it is 1.5 turn. Beyond that we should not go. Now you see, once you are giving rotation from handle, the chevron is moving and device is taking turn. So now it is almost 1 turn, and we also in between see the impedance rising, going to 500, 600. Current of injury we monitor 1 or 2 times, and now we are undocking it. Once we are okay with after we have 1.5 turn, we undocked it, and you can now see electricals, good current of injury. Impedance also around 780, 800. That is very good. The impedance should not go beyond 1000 or 1200. It means it's too much, and you can perforate. And now you see the pacing threshold. So the pacing threshold here can be higher because of the injury hematoma. So once you have a good current of injury and a decent threshold, you should be okay. We see the stability by giving break more and deflection more and less. And once it is coaxial, now we are okay with then we will disconnect the device by misaligning the tether. And you see here we're trying, when one tether is still attached, so it is not disconnected. So we advance the protective sleeve in these situations and cover that, so that and then the connection and the yes, you see this is disconnected now, and we remove it. And with the same sheath, before we take the the atrial LLP, with this protective sleeve we give the contrast in the right atrial appendage after going there. So you can see it, we can easily negotiate. Atraumatic, this catheter is very atraumatic, the sleeve. And now we can see the appendage so well visualized, and this is the place where we have to take our atrial capsule, atrial LLP. So the preparation is similar. We flush all the ports. We take the device, misalign it first. So, and then once we take it inside, we align again. We align, and now you see how we dock. So we remove the protective case in which the device was kept, and you see how we dock it. We just pull the yellow part, blue part, and it is docked. Then we take the capsule inside the protective sleeve with simultaneous flushing, and now we lock the catheter. I will show you how to lock the catheter. You see how it is locked. So catheter is locked. Now it will not go forward and backward. And then with bypass tool being fixed, we take the device up. So the device goes exactly at the same place, but before that we do the similar exercise of seeing the blood pool impedance by unsheathing the device. And you can see here, we see the blood pool impedance again. We see the electricals, how the injury current of blood pool impedance, and then we resheath it with protective sleeve. We advance it to the same place, and you can see the movement. It is already in appendage. You can see the movement of the entire catheter. This is in the appendage. We go LAO, we see exactly, confirm it, and the previous and the new position we confirm, and then we thought we should be coming little down, and with contrast we confirm it. So you can see here how the counterclockwise rotation torque is given. This is inside the L appendage, RA appendage. So we want to be at base, we little lower with the maintaining the deflection counterclockwise. Almost the device is up, the catheter is upside down, so it has come little more, more than what we required. So it's a good position, I think. Yes, we now push it and see that the protective sleeve is getting bent. It means it is touching and the tissue, and then so now we are unsheathing the device. You see now, once the RA position looks okay, we are unsheathing it, and we remove the brake. We look at the electricals, the positive and negative deflection, and we also see the impedance. It is to be little more than what which was there. And once we are okay with that, the electricals, and we start screwing with capturing the chevron in cine, and looking for 1.5 rotation. So 1.5 rotation we are making, and after we are okay, in between we pace and see. We also look at electricals sensing. And after all this, we have to undock it. You can see here the white part comes closer to blue part. Untether, the tether is longer in right atrium, and once in tether mode undocked, we see the all the parameters again, the sensing and the pacing. So after then we do a duct test. Beautiful movement in the RO, in the appendage. And then finally we misalign the tether and disconnect the device, the LLP2, from the delivery tool. The covering, protective covering goes up, and finally we come out with the figure of 8 injection, and the 12 chamber AVEIR implantation is done, with the patient now ready to go home next day.